Hi, I'm Scott Benson. I'm a child psychiatrist and I practice in Pensacola, Florida. And welcome to the conference, the training today. In this webinar, we're going to talk about working with children with mild developmental disabilities. Dr. Castellanos is going to speak about identifying these children, the evaluation that would be helpful in defining exactly what is causing the behavioral disturbance that they're having. And then the steps that go into developing a treatment plan and implementing that treatment plan. He's particularly going to focus on the medications. At the end of his presentation, then we're going to have Anna Baznik, who's with Empower. She's going to talk about the use of telepsychiatry and how telepsychiatry can be a new access point for children who have these particular kind of healthcare needs. So telepsychiatry should be a real boon to pediatricians who are seeing these children in their office and in their clinic. At this point, then, I'd like to turn it over to Dr. Castellanos, who's with Florida International University, and I'll let him introduce himself. Dan?
As you heard, Dr. Benson, I will be taking about 40 minutes where we will be providing a little bit of an overview of some evaluations and screenings for children with neurodevelopmental disorders. The predominant focus will be on autism spectrum disorder, or ASD. There will be some discussion about kids with intellectual disabilities. And then, as you know, there's a broad category of other children that fall with these non-specific neurodevelopmental symptoms as well. And this is especially in light of the CDC's report last week indicating an increase in the prevalence of ASD in the US population, and again, documenting a trend of how it's increased in the last several years as well. We're not going to focus on your diagnosis of autism spectrum disorder or intellectual disability, formerly known as mental retardation. We're going to focus on the most common behavioral health problems or symptoms that individuals and families present to primary care practices. We're going to focus on some of the psychosocial interventions, and as Dr. Benson mentioned, we're going to discuss quite a bit on our evidence base of what we know and don't know regarding the use of medications for these target symptoms. And then we're going to talk about throughout this when it's appropriate to refer. That is, when it's appropriate to hopefully manage and try to treat some of these difficult symptoms in a primary care population, and then when to refer on to a specialist. Needless to say, the use of medications is usually reserved not for mild neurodevelopmental disorders. It's generally for more moderate or definitely more severe symptoms. So we're starting a little bit with the more severe end of the spectrum, and then we can have a bigger discussion about the moderate to milder end as well. When we've looked at the literature, and when you discuss with any practitioner in a primary care setting that deals with kids, and particularly kids with neurodevelopmental disorders, there tends to be a group or cluster of symptoms that present most commonly. They include symptoms such as hyperactive, impulsive, and inattentive symptoms. And please note that this is within the context of ASD or ID, and this is not the presence of a separate attention deficit hyperactivity disorder. Other common presentations, and most parents will tell you, will include sleep disturbances. Others include aggression, and aggression can have different forms depending on the typology or how you categorize aggression. But broadly, we're talking about irritability, severe irritability, self-injury, aggressive behavior, and explosive emotional angry outbursts or mixed outbursts. We're going to discuss some anxiety. And then lastly, we'll address a little bit about restrictive and repetitive behaviors, which, as you all know, are one of the core symptoms of autism spectrum disorder as well. That's going to set the framework, even though we'd be glad to field questions. And when we get into the question and answer period about any other target areas, but by far those have been the areas that have been the most frequently presented in any primary care, and actually in psychiatric settings as well, and the ones of which medications have been utilized to address these issues. Then a lot of our medication guidelines, as you know, are based on the work from the University of South Florida, from the Florida Medicaid Drug Therapy Program for behavioral health as well. And that's a point of reference for you all afterwards. What do we know about interventions for individuals with ASD, and not for necessarily the core symptoms of intellectual disability or autism spectrum disorder, but for these behavioral issues that we've discussed briefly? We always recommend starting with evidence-based psychosocial and non-medication interventions for this population of children. And we'll get into some of the evidence-based practices in a second, but in general, it includes interventions such as physical therapy, OT, occupational therapy, speech and language therapy, etc. We know that intervention early is very important, and actually one of the indicators of prognosis or outcome in autism spectrum disorder specifically. We know that when children present with multiple problems, which children present very complex and multiple behavioral and other problems and manifestations, that it can sometimes be overwhelming, and that there could be a variety, but one should really look at it, and in your assessment and working with the family or the caregivers, determine a hierarchy of priorities or determine which are the most important. And it can be tough at times, but that they should really look and determine which is the most severe or the most impairing symptoms and target your interventions at those first. That is, priorities are vertical and they're not horizontal, lest families become overwhelmed that they have to implement so many different interventions, and that's hard to sustain over time. As you've heard in other presentations, there is a strong emphasis on monitoring and measuring at baseline symptoms and measuring symptoms over time. It's a way to assess severity, it's a way to quantify, but it's also a way to demonstrate an improvement or lack of it. And if there's a lack of it, hopefully having that feedback incorporated into the treatment plan to decide what to do differently or what to do next. And sometimes even having those measures helps with funders or third-party payers in demonstrating or quantifiable changes to be able to justify the interventions. In children with neurodevelopmental disorder that present milder problems, some of those behaviors, those target symptoms that we discussed earlier, we recommend at least a 12-week course of psychosocial interventions before you even consider medications, right? So you want to really provide a good therapeutic trial of these interventions before you can either say those symptoms or problems are sufficiently severe or sufficiently impairing to even consider or entertain the use of medications. In children that present more moderate or severe symptoms, and again, severity and impairment, right? The higher level of intervention may be appropriate initially, along with the psychosocial intervention. That would be combined treatment. But again, it's gradated based on the severity of those symptoms. Children with all kids, we know the involvement of parents or caregivers is essential, and frequently it involves not just parents, it involves any other caregivers, whether that's grandparents, nannies, other caregivers, as well as, if in the ideal world, the involvement of the school environment to help manage those behaviors. Because again, one of the ways we look at interventions, and one of the ways our assessments are focused, is looking at the cross-situationality of the behavior. That is, how do those behaviors express in different environments: home, school, social as appropriate, in front of you in the office or your clinic, and how then do you tailor the interventions for the different environments. Couple of notes on medications, and you've heard me allude to this already. One is that medications are not considered the primary intervention for any children and adolescents or youth with autism spectrum disorder, intellectual disability, or actually any neurodevelopmental disorders. And that when we do use these medications for these behaviors, they should always be utilized in conjunction with these other interventions. That is, medications should not be the sole intervention in the absence of other interventions. And in reviewing different databases and looking at evidence-based interventions for children and adolescents with neurodevelopmental disorders. Just going to briefly outline a variety of these interventions, and the National Professional Development Center on Autism Spectrum Disorder has a very nice summary on their website as well, as you can see here. Others, continuing social skills training, as you see, it's one of the core deficits in autism spectrum disorder specifically, and it's one of the most frequently utilized interventions as well. It was previously called social skills group, but now we broaden it to social skills training. And then functional behavioral assessment and a bunch of other interventions, as you can see, are all evidence-based psychosocial interventions for children, in this case, particularly with ASD, autism spectrum disorder. And they're there for your review. It goes beyond the scope of this presentation to review in detail any of these psychosocial intervention, as the basis of my portion of this presentation will be predominantly or primarily focused on the use of medications, etc. Having looked at it, you know, in general, pediatric, the American Academy of Pediatrics has their guidelines on screening and surveillance for neurodevelopmental disorders, assuming that someone has gone, an individual has received a specialized evaluation for the assessment of the possibility of a neurodevelopmental disorder. There's been an appropriate workup and diagnosis, and in general, as we said, we're going to focus on autism spectrum disorder and intellectual disability. And so assuming that all of that has happened, and assuming that you have some of your references here, and Anna's going to talk later about the psychosocial treatments as well, we're going to move on then that these children present to your office or your clinic with these different behavioral manifestations, which are not part of the core symptoms, but that can produce difficulties. And some of you that have heard my presentations in the past, you see I've used this same graphic, that how does one decide, and this is a very crude or global way of saying, how does one decide if medications are indicated? Well, the short answer is the amount of severity and the amount of impairment that is being produced by the symptoms and the behavior. That is, that the more severe the symptoms and the more they are impairing one or more aspects of functioning, and hopefully in one or more different settings in the child's life, that the more likely the use of medications are indicated. And so that there's a threshold there, right? And that could apply to, I guess, most of our medications in general, right? If you have a little bit of anxiety, but if you're functioning pretty well throughout most of your daily activities, sad to say, join the club, as everyone has something, and therefore medications may not necessarily be indicated. But the more severe and the more impairing the behavior, the more likely medications are going to be utilized. So then let's move on to the whole cluster of hyperactive, impulsive, and inattentive symptoms, which are very frequent in the ASD and the ID population. And actually, up until 2013, in our DSM nomenclature, it was an exclusion criteria. A child with ASD could not have ADHD at the same time, because it was believed that these symptoms were all inherent as part of the autism spectrum disorder. So we're going to assume that there isn't a separate comorbid, co-occurring attention deficit hyperactivity disorder, and this youth presents with autism spectrum disorder, but with these ADHD-like symptoms, but it's not really the full ADHD. And recognizing all the difficulties inherent in the diagnosis and the challenges in trying to tease that out as well. And why is that important? Because there are differences in the treatment. So if you go to the USF website, to the MedicaidMentalHealth.org website, you'll see there's a whole different protocol for ADHD in children and adolescents and neurotypical children, and that there are a few differences in the ASD ID population who present these kind of symptoms. The clinical pearl or caveat is response to medication does not help differentiate the differential diagnosis. That is, you provide a stimulant, the child improves in certain target symptoms or behavior. That does not equal that child has ADHD. That just a mere response to medication does not make a diagnosis. Let's go what we know. And as you, again, as I mentioned in other presentations, these recommendations are based on the strength of the evidence. And one of the things that we know is that the strength of the evidence specific to the ASD and the ID population in youth is much less compared to the general population of children and adolescents. So that there is an emerging literature, and you'll see, we'll highlight a couple of the differences. But again, it's much more limited, with the gold standard being randomized controlled trials as the most heavily weighted scientific information to help make informed decision-making and evidence-based practice. So if a child presents and the parent provides sufficient information and information is obtained from other settings, and that information regarding the hyperactive, impulsive, or inattentive symptoms is of sufficient severity and sufficient impairment to warrant the use of medication, your level 1 intervention is going to be a methylphenidate-based product or guanfacine, which is an alpha-2 agonist. And guanfacine either in the immediate release or the extended release form, guanfacine ER being sold commercially as Intuitive. And the recommendation is to begin one medication, monotherapy, and to be very cautious. Now, we're cautious with children in general, but even more so because we know with kids with neurodevelopmental disorders, the clinical experience and actually the literature documents that they are more sensitive to adverse side effects than neurotypical kids. And that because of that, closer monitoring is recommended, and that the possibility of requiring lower doses is there. That is that it's not your typical ADHD protocol, as I mentioned, and maybe the optimum dose will be lower than neurotypical kids. We also know that treatment with these medications and for these clusters of symptoms is modest, with about 50% showing improvement. If you look at the ADHD literature, you expect a much higher rate of improvement for uncomplicated ADHD, 65, 75, 85% monotherapy first treatment trial uncomplicated. As we mentioned, close monitoring of the side effects, so that if you typically begin at a much higher dose, you may want to consider stepping that up slower. And ensuring that there's not only an appropriate response, but tolerability. Vital signs should be obtained at each visit. As we know, a routine EKG is not documented unless there's evidence of some specific cardiovascular disease, or especially a first degree biological relative with SUD, sudden cardiac death, SCD. And that you initiate monotherapy, one medication with either a methylphenidate-based product or guanfacine, increasing the dose carefully until you receive the desired treatment response, or there's the emergence of treatment-limiting side effects. And then at that point, you would either say, wait a minute, either we need to decrease the medication or we need to switch the medication because either the response is suboptimal or the youngster is not tolerating it. If that one medication produces a partial response, we're targeting this amount of impulsivity, this amount of inattention, we're targeting these motor behaviors, this level of activity, etc., then we consider it to be partial with one medication. Then you can consider combination therapy. That is, if you start a stimulant, a methylphenidate-based stimulant product, then you optimize the dose and you think that that's a partial response, then as a level 2 decision, then that's when you consider combination or adding a second medication. Please remember, the recommendation is you begin with one medicine at a time. You don't begin with combination therapy. If you begin a guanfacine-related product and you get a partial response, then it's the same thing. You consider adding another stimulant. Or if you're using guanfacine, you can consider combining an immediate release or short-acting preparation with a long-acting preparation. Alternatively, the literature supports and our scientific evidence supports that you could either then decide not to utilize combination therapy and switch the medication to atomoxetine, which was sometimes sold commercially as Strattera. And atomoxetine, as you know, is similar structurally as an antidepressant, and it takes a much longer period of onset. And sometimes, depending on the severity of these symptoms, there's not that benefit, the luxury of waiting a few weeks for those beneficial effects. Level 3, and this is where there is a clear difference, right? Level 3, we can consider the use of an amphetamine preparation. Now, in the regular ADHD guidelines, amphetamine preparations are recommended as a first-line medication. There's no differentiation between methylphenidate or amphetamine-based preparations as far as efficacy and choices, but with children and adolescents with neurodevelopmental disorders, there's much less literature on the use of amphetamine-based preparations, and there is a tendency to have, as I mentioned previously, more sensitivity to the side effects. But we also recommend at this level, if you've gone through one medication, if you've gone through combination medications or a second medication, that this should be the point where you should really strongly consider obtaining a consultation and or referral to a child and adolescent psychiatrist, a developmental behavioral pediatrician, or a pediatric neurologist to help understand better what is happening, what is not responding, and what any possible alternative interventions may be appropriate. This means that you continue your treatments until then, but that you should really, really look at that. And that in other guidelines for, let's say, the neurotypical ADHD population, those decisions to refer are usually made a little bit further down the line. And so know that things like parental management training may help, and you should continue all your psychosocial interventions, being very behaviorally focused and implementing those throughout the course of treatment. As with our ADHD guidelines, there's not recommended switching classes or combining classes, better said, of alpha-2 agonists, that is clonidine-based products and guanfacine-based products. You should stay within class. And that the use of antipsychotic for ADHD symptoms per se, or as sedatives. And the reason being is that the metabolic profile is much more negative than some of these other medications, and that the potential benefits are not outweighed by the potential negative or the risks with these medications. This is a large, extensive table with all of the I think there may be one missing, but the great majority of the stimulants that are utilized to treat ADHD and the stimulants that you would be considering in this population. And you can see there's a variety of choices. They're all basically variations of each. It's just the method of delivery and the route of delivery are different. And so that provides some options for our neurodevelopmental population that sometimes have difficulty swallowing, etc. And again, pending your formulary and getting it approved and availability. So for example, the Daytrana patch, which still is on the market, is sometimes difficult to obtain. And that's the transdermal absorption of the methylphenidate. It's placed on the hip, etc. As we move to our non-stimulant medications, you can see includes the atomoxetine and your alpha-2 agonists, as you can see outlined here, with both the immediate release and the extended release preparations for that group of kids. And so in summarizing those medications, this is the cheat sheet or the bottom line. And these are all off-label, because we are not addressing specific treatment of attention deficit hyperactivity disorder. We are treating hyperactive, impulsive, and attentive symptoms within the context of a neurodevelopmental disorder. Again, summarizing briefly, we begin with monotherapy, one medication, either methylphenidate-based product, and you saw that from your table, or a guanfacine-based product, either immediate-release guanfacine or extended-release guanfacine. If that first choice is ineffective, you then look at changing the preparation. That is, that if you've gone through a methylphenidate product, then that doesn't seem to be helping, then you can move to a guanfacine monotherapy, another iteration, another trial with the other class, or vice versa. If you move on and you've had a partial response to one of those medications, you consider combination therapy. That is, if you started a methylphenidate stimulant product, you can add or augment with guanfacine product and vice versa. Or you consider the use of atomoxetine monotherapy only. And then thirdly, as we mentioned, you either move on to an amphetamine-based product. As you saw, those sold commercially, anywhere from sold commercially as Vyvanse or Adderall-based products, or the old Dexedrine products, etc. And you definitely consider at that point reassessment and consultation or referral to a specialist, depending on access, depending on your system of care. So what do we know as well is that insomnia is going to be very common, or sleep issues are going to be very common. And so let's transition on to sleep issues in this population. And so we're going to talk a little bit about the use of medication for the treatment of sleep disturbances within the context of neurodevelopmental disorders. If you look at all the different studies, and actually if you talk to all the families, about 80% of youngsters with autism spectrum disorder and intellectual disabilities present with some kind of sleep difficulties. And if you combine that with the kids that present these ADHD-like symptoms, the impulsive hyperactive symptoms, you could see that tends to worsen. And we know in the ADHD population per se, there's a fair amount of kids that present sleep issues as well. And by sleep issues, we're talking about predominantly insomnias and not parasomnias. So insomnias are difficulties falling and staying asleep. And so when we look at the level of evidence, melatonin. Melatonin by far has the most robust evidence for the treatment of sleep issues in children with neurodevelopmental disorders. There's been several studies and case reports and meta-analysis documenting that, and that's why the level of evidence is considered classified as A, that is the highest level of evidence. And so recommend always starting melatonin. The typical starting dose is about 3 milligrams, but it could be 1 to 10 milligrams all at bedtime. And usually you look at adjusting that dose after 1 week increments. Now, remember, the parents are at home, and the parents are sometimes desperate to get those kids to sleep. And sometimes you may hear the pressure that you want to escalate those doses quicker, but it's usually you try to wait about a week before you escalate the dose, and administering that dose about 30 to 60 minutes prior to bedtime. We've heard stories of people saying, hey, I've tried melatonin and it hasn't worked. Well, one of the things we know with these over-the-counter products is that there can be a whole variety of clinical quality in the products and differences in the different proprietary brands. And then here's a couple of examples of studies that have looked at this. So meeting the margin label of the claim there means that if it says it's supposed to have 1 milligrams of melatonin, the US government requires it to be either 90% or 100%, that you have 10% margin either way of the content. But that studies have shown that a large amount of these products that are sold over the counter do not fall within that margin. So if they claim to have 1 milligram, they could have 0.5 milligram, 0.4 milligram. They could sometimes have more, but it's generally less. Then the Cerezo study was an international study, comparing the products in Spain and the United States. So this is not just a US issue. And that if you look at it as well, a lot of these products contain other chemicals and other products, such as serotonin or 5-HT5-hydroxytryptophan, the precursor, or tryptophan, so that they are not as pure as they should be. So that failure to one proprietary type of melatonin doesn't mean the child necessarily is not responding to it. That you should go ahead and try a second or third product. And you should always look for melatonin products that have third-party testing. That is, that they have independent laboratories that have tested the quality of the product and not obviously internal testing, which may be a little bit of a conflict of interest. So if you've tried one product, two products, or three products of melatonin, if you think you've escalated the dose enough where you've had a good trial of the medicine for long enough period of time at a high enough dose, and or if there's rate limiting side effects, the second line medicine is Clonidine. Now, Clonidine, the evidence base is less robust, but there are a few studies, especially open trials, that do support its use. So Clonidine is considered off-label for the use of sleep in children with neurodevelopmental disorders. And all of the studies have been with the immediate release Clonidine. Usually you begin low, about a quarter of a tablet to a full tablet at nighttime, and then you go increasing the dose every week, again, until you get sufficient improvement in sleep or you get rate limiting side effects. So that you do want to titrate up the dose again about once a week to see where that leads you. After that, there's not much literature on what else to do with kids. So the use of medications like quetiapine, so commercially as Seroquel, there is no strong, robust studies that document that it actually helps in this population, even though it's used frequently. If you look at over-the-counter medications like diphenhydramine, sold as Benadryl, there are no studies in this population that show it. And actually, in the general neurotypical populations, there's only been one randomized controlled trial in the use of diphenhydramine, and it was done way, way back. And there's actually been a couple studies that have been negative. So after these two medications, there's not much guidance on what to do to help these families. So from there, you use your clinical judgment. So melatonin is your first line, and then you move on to Clonidine. So let's talk about aggression. Well, as you heard before, if the aggression is mild or minimal, no medications, right? If the aggression starts creeping from mild to moderate, if you start looking at it and you say, oh my gosh, it is more frequent, it is more intense, and it's lasting longer, then you can utilize one of these alpha-2 agonists that we've been talking about, whether it's Clonidine or guanfacine, even though there's just a little bit of literature on that. But it's considered our first-line recommendation because the side effect profile is more benign than some of the other medications we're going to talk about. And as you can see on here, that's considered an off-label recommendation for the treatment of aggression. Our level 2 recommendation is really for more moderate, but usually for more severe aggressive behavior, then it's using antipsychotic monotherapy. And that's very specifically risperidone, sold commercially as Risperdal, or aripiprazole, sold commercially as Abilify. And these are FDA-approved medications where the labeling calls it for severe irritability, including aggression, self-injury, and significant mood lability. Those are those emotional explosions. If the child presents with autism spectrum disorder, either risperidone or aripiprazole is recommended. You begin with one. Again, you increase the dose until you receive the maximum benefit from the medication, or there's rate-limiting side effects. And if not, you switch to the other. So if you begin with one and you don't get the desired benefits, you switch to the other, all monotherapy. In the intellectual disability population, very specifically, the majority of the work's been done with risperidone, and the recommendation is to utilize risperidone in that population. If you've tried these two medications, aripiprazole or risperidone, then you've either seen that the child doesn't tolerate either one, or that there is minimal or little improvement with those medications. Again, that's when you should be considering reassessment and or referral or consultation with a specialist. Because after that, there's very limited literature supporting the use of which other medications. So sometimes you can consider the use of other antipsychotic medications based on their side effect profiles to help target these aggressive behaviors. But that, again, it's a little bit less based on the scientific evidence, and it'll be based on your preference and choice and funding of and your third-party payment for your medications. Always monitor for the adverse side effects of these medications, please. And again, here is your bottom line assessment of your cheat sheet of these, knowing that clonidine and guanfacine are considered off-label for the use of aggression in this population, and actually in any population. Information about the dosing of these medications. And then we move on to anxiety. You're going to see a lot about anxiety in this population. And what do we do, doctor? And I see my child is anxious. A word of caution, especially with language skills, is that sometimes behaviors get attributed to be anxiety, but if the child presents with limited verbal skills, it's sometimes difficult to assess if that really is anxiety or being interpreted as anxiety. If with anxiety, fear-based anxiety disorder, such as social anxiety disorder and generalized anxiety disorder, there's very little evidence of use of these medications. It was a struggle because clinicians were asking about the possibility of some medications. And if medications are to be considered, you do need to know that there is very little scientific literature base to support this use. But if you are going to use them, you should consider the use of medications such as sertraline, it's sold commercially as Zoloft, fluoxetine, sold commercially as Prozac, or buspirone, sold commercially as Buspar, and then monotherapy with each of those. But please keep that into perspective that we know very little on the use of these medications. And if you've tried one or two of those, you move right on to reassessment and consulting with a specialist, again, because it may not be a full anxiety disorder, or it may not be anxiety that will be responsive to medication. So you really want to move on and not keep adding medications, combining medications, lest that leads you into further trouble. And lastly, the restrictive and repetitive behaviors, which are the things we know are some of the core symptoms of ADHD, and which medications for the treatment of that. And we have been silent on that. Silent because there have been no studies that have shown the medications will help any of those behaviors. And people will sometimes consider those to be OCD, but it's really not obsessive compulsive disorder per se. It's these RRBs, restrictive and repetitive behaviors, within the context of that, so that there is very little clinical guidance on what to do, and or if any medications actually help those behaviors. So in summarizing our takeaway points is that youth with neurodevelopmental disorders present a unique and a vulnerable population of individuals with very special healthcare needs, that you should really perform a good initial evaluation to obtain that baseline assessment and looking at the functional domains that you really want to target or you really want to look at intervening with, that you want to use validated measures. And you saw that there's no specific measures for this population. So if you're treating, if you're assessing hyperactive, impulsive, inattentive behaviors, you would use the same ADHD scales, even though this is a different population. And you start with your evidence-based psychosocial, then non-pharmacologic interventions, then that the medications or pharmacotherapy is never the primary treatment, or this should be the sole treatment of youth with these problems. Clinicians are left with this decision to make, that children with these behaviors, especially the more severe behaviors, present to their offices and their clinics, and they have to make decisions, and these decisions are based on this typical weighing of the potential benefits of medications and the potential risks of medications. But words of caution and takeaway points include: begin with one medication at a time. Beginning with two can bring complications. If you're going to begin with any medication, really look at the justification if you're going to be adding a second medication, and certainly if you're going to be adding a third medication, but really look at that. You need to continue your psychosocial treatments throughout, and you need to cautiously monitor for adverse effects. So with that, I turn it over to Dr. Benson, and thank you.
I know you mentioned several times about the importance of the psychosocial treatments And too often, I think we hear that as somehow we're supposed to refer these children out for the psychosocial treatment. There's a real movement to say that within the context of a brief clinical intervention, that people can do good psychosocial interventions. So if you look at behavioral therapy, one of the things that you want to do first is you want to look at, do we count, or we have to count the behaviors. We're looking at how often do they have these behaviors and where do they have the behaviors. In my own practice, I see families and they talk about the children's disruptive behaviors and temper outbursts. And when you drill down and you're looking at the context, well, one of the things that you find is that at home, it's almost always over homework, because the parents too often come with what I think all of us believe, that I guess if the teacher says you're supposed to do the homework, you're supposed to do the homework. And so the parents and the kids get into these big battles at home. And what we always hear in our practice is that they spend 30 minutes arguing about 5 minutes of homework. And so once you hear that, and once you know that that's the context of a lot of the aggressive outbursts, then there's some interventions that you can do. In my own practice, the research on homework shows that the only thing that homework does, the consistent benefit of homework, is it gets children to hate school. So I have a lot of parents to interact and interface with their teachers and try to figure out something different to do than these homework battles that they have every night. And that's just one example. So consider learning some brief psychosocial behavioral interventions that could fit into the brief clinic time that you're planning to meet with this family and meet with the child. So the next part of our presentation today is we're going to talk a little bit about how we can use telepsychiatry or telehealth as an additional resource, so that when you have these very difficult children, how you get them, how can you get some professional interface so that you can get some other additional insights to some of the management techniques. So our next speaker is going to be Anna Baznik with Empower, and I'm going to turn it over to Anna.
Thank you so much. I'm excited to be able to present on telehealth today. As he said, I'm Anna Baznik, and I am the CEO of Empower. And a little bit about us. We are a nonprofit. We originally started in Central Florida. We actually specialize in mental health, substance abuse, and child well-being treatment. We were founded in 1994, and however, as of tomorrow, we actually merged with an organization called The Grove, who has 47 years of substance abuse treatment here in Central Florida. So our roots are going to go back farther. We are known as the state's actual leader in telehealth services. We began doing these services 6 years ago, which I'll talk about in a little bit. We now, because of telehealth, are doing services statewide. We're not located in Central Florida anymore for that provision of services. We serve about 11,000 individuals and families per year via telehealth, home, and community-based services. Most of those now are actually virtual. For our primary funding streams, and this is important because when we focus on telehealth, Florida is actually behind the rest of the country. Believe it or not, in telehealth, but Florida Medicaid is way ahead of other providers, insurance providers here in Florida. So our primary funding streams right now are ACA, which is Medicaid, Agency for Healthcare Administration, the Department of Children and Families, and the managing entities, which oversees the substance abuse and mental health treatment. And then we are also providers of for Medicare and Cigna, Aetna, Florida Blue, TRICARE. But the key here is in Florida, private insurance is not necessarily covering telehealth services right now. If they do, it's with a kind of not your regular practitioner, it's the teledoc type of services. So that's important as we go forward from an advocacy standpoint, because unless you do have Florida Medicaid or you are working through the state and qualify for those services, it's a little difficult to get funded. And I do want to mention also, unlike my two co-presenters, I am not a clinician. So I'm coming at it from an agency standpoint, as well as meeting needs in the community. So this is one of my favorite slides, just to show from a psychiatric type approach. The data in our country shows that you need approximately 26 psychiatrists per 100,000 people just to meet our current mental health crisis. The national average is 10 per 100,000 individuals, and Florida has only 7 for 100,000 individuals. And if you narrow that down even farther for a child psychiatrists, there's about 4 for every 100,000. And the average age of a psychiatrist in our country is over 55. So you couple those two data points together and you see why it's difficult to get appointments with psychiatrists, and it's especially for some of our rural areas, and even in the Orlando area, it's the wait list and the ability to get into treatment when you need it is not as easy as we would like it to be. So telehealth is a solution, and as we have implemented our telehealth program over the last 6 years, I've kind of evolved how I look at it. I talk about my dad a lot. If my father were alive today, he'd be 104 years old. And when he and my grandfather needed medical treatment, a physician came to their home on a horse and actually came in and did those services. We've evolved into where we are today, where we have specialty practitioners and we're used to going to doctors' offices or hospitals. But what telehealth does is a solution. It's not a treatment. It's a solution that, for me, brings that practitioner back into our home, but they're not coming on a horse. This time they're coming with a smart device. So it just makes the access a lot easier for our clients, even for our practitioners. It gives them a little bit more flexibility in how and when they can see clients. A lot of people, when they hear the word telehealth, they think, oh, it's too complicated. I can't figure out how to use the technology, or it's a new service. And what I really want to emphasize is it is not a new service. It's just a mechanism to provide the service and how you actually obtain the service. The service you actually get is the same exact service you would get face-to-face, particularly in psychiatry and therapy, because you don't have to lay hands on individuals. There really isn't much difference. And some would even say it's even better via telehealth. This is a picture of Allie. She was our very first telehealth recipient, March 29th, 2013. And just a little bit how we got into this, a lot of the clients that we see are Medicaid clients, or they're involved in the child welfare system. And if you've ever understood or had to treat youth in a group home facility, it's not a fun practice for those kids. They often have to get on a van and they're driven to a practitioner's office by what's called a transporter, who may or may not know a lot of information about those clients. So when they would get here to our actual office, the kids were all upset. They had to wait for each other. They were missing school. It just did not make sense for us. So we had to figure out how to make it easier for our clients to get to us. And actually, we couldn't get a client or a psychiatrist to go to Brevard County to save our lives. And Brevard, to me, is not a rural county. We're here in Orlando. So that's how we got into this, is to actually look at how can we make access better and avoid all of missing work, missing school, all of that comes together. So as I sit here today, this number changes every moment, but we've done about 130,000 telehealth services to this time. We're up to about 800 per week, and we have about 50 practitioners that work with our clients. We have also reformulated how we're working with our practitioners. We have teams that are led by a psychiatrist, and on that team could be a psychiatric ARMP or a psychiatric physician assistant or a physician assistant. We have licensed social workers and master's level therapists. So we work in teams to better serve those clients. And obviously, the more difficult cases or the more complex would be seen by the psychiatrist. But if somebody is stable and on just a medication check or some sort of service like that, we would use our practitioners, our ARMPs and PAs. And we're also in the process of establishing virtual response teams to really help prevent a lot of the Baker Acts and a lot of the disruptions, placements of children in the child welfare system, or really just to, what I would say, beam in the services to the family or to the individual to help stabilize them and get some ways that they can work through their symptoms. And that way, if it's a true Baker Act or a true hospital admission, then we would help do that. But otherwise, we want to keep the client in our own home. As I said, the services that we provide are really no different in our psychiatric program than we would do in our face-to-face. Our therapists do the individual therapy or family group therapies. We do behavioral health assessments, psychiatric evaluations, medication management. We just get approval through our state licensure to do substance abuse outpatient services, and then child well-being services, and I'll explain that in a little bit too. So part of the beauty of what we did over time is we took our time to design this, and I think this is particularly important for the topic we're talking about today in the ID population. Oftentimes, we need multiple practitioners or multiple individuals in a session or to talk to each other about a particular client or participate in the session. So our platform is designed so that we can have multi-participants. It is a HIPAA-compliant platform. We use MEND. It's very easy to use, but for example, if you needed your medical practitioner, like your pediatrician and your psychiatrist and perhaps a case manager, a parent, and they're all in 4 different places, you can actually all participate in the same appointment and the same conversation with or about a client to decide the treatment. It works beautifully also for the child welfare system because there's often guardian ad litem's or foster parents, other guardians that need to be involved, and they need to be in the part of the case consultation or the treatment team. And it's, again, very simple. You can use your smartphone or smart device. All you need is an internet capability and a camera. And if most of our clients use their smartphones, you'd be surprised even in some of the Medicaid populations, some of the lower income, most folks do have a smartphone, and we have really run into very little pushback or where folks don't have that access. If we do not have it, we set up what are called hub and spoke sites throughout the community in places where individuals often go. It could be a church, a domestic violence shelter, a homeless shelter, anywhere where folks already are and have that equipment, we can make that a spoke site and clients can go there for treatment as long as it's in obviously a HIPAA compliant place. We don't want it to be in the middle of a Starbucks or anything like that. So where can they be seen? Medicaid changed their rules about almost 2 years ago now. They originally only allowed hub and spoke configuration. Now they allow what's called direct to consumers. So an individual can be seen anywhere. They can be seen from their home, from work, anywhere that they have privacy. And the same with practitioners. They no longer have to be in our office. They can be in their home office or another, again, place that is HIPAA compliant to conduct the services. And that was actually a game changer for us because, and for clients to actually access services, sometimes it's not an easy thing. Many of our clients, if they miss work, they don't get paid, or they miss school, and oftentimes based on their diagnosis or their situation, they may already be behind in school. So it really makes it easier for the client. We have several clients that may go out into their car on their lunch break and have their appointments. It's just, it brings us right to the client and is less disruptive. We had an epiphany ourselves and realized our clients don't just need us Monday through Friday, your typical office practice hours. So we have changed our office hours to accommodate our clients. So we're open Monday through Friday, 8 to 8. This is all virtual, and Saturdays from 9 to 1. And we're working on our 24/7 virtual crisis response team. In September of this past year, we actually closed all of our physical offices. We are completely a virtual practice right now. So individuals with intellectual disabilities, this is something that a lot of our clients do present with, a lot of the previous speakers were talking about. This is not as far along in the telehealth world here in Florida as the behavioral health systems are. We do some of this treatment. We have several individuals that have co-occurring and they have difficulty leaving their home. So we actually, before we were even allowed to do the direct to home, we had special permission from some of the Medicaid plans to go right to direct to consumer. A lot of clients are often difficult to transport or to move from where they are, their home or their group home, wherever that setting is. So we do treat clients for the psychiatric component of their what's going on with them individually through telehealth. Our vice president of behavioral health is also a behavioral analyst herself. So part of what we do want to develop, and I think is much needed, and I'm sure you're all on this webinar for that, is the ability to be able to bring behavioral analysts to the home and to actually observe clients' behaviors in their own setting and can actually prompt families to implement the behavioral plans. To be seen in the caregivers, to be seen in their natural environments is huge for treating this population often. And even just to observe or to pull other individuals in at the same time. So we're working really hard to develop this program. I think right now, a big piece of what we all need to work on is the advocacy. As I said, Florida is behind, and private insurance is behind in the state of Florida. This is a no-brainer. What holds true with specialty practitioners in the medical field also holds true with behavior analysts. They're in such high demand and they're fewer and far between often, that this allows more individuals to treat more people by not having to travel and leave their homes. Again, as I said, equipment needed, basically just a smartphone, tablet, a PC, or a Mac with a camera and internet connection. We have staff that will help clients set up ahead of time before their actual visit to make sure that they have their equipment set up right. And it's basically just an app that you download on your phone. The clients get a text message from us several times beforehand to prompt them for their session. If a doctor's running behind, they go into a virtual waiting room. There's 24/7 help for the actual platform itself if there are technical error issues going on. We have learned a lot by trial and error over the last 6 years on what is needed and what needs to work, but so far so good, we're getting there. A key piece that from a historical perspective, when Medicaid first allowed telemedicine to be paid for through the Medicaid programs, at the same time, the Florida Board of Medicine implemented a rule, and it's basically revolves around the pill mills, that you could not prescribe a controlled substance via telehealth in an outpatient setting. And that's a problem for us in the mental health arena because many therapeutic drugs for mental illness are a controlled drug class. So we actually did a petition and wavered for a variance to the the Board of Medicine, and Empower was granted a waiver, the only one of its kind in that time for Florida practitioners to actually be able to, in a pilot, to prescribe non-narcotic controlled substances. There are no psychiatrists on the Board of Medicine, or there weren't at that time. So they didn't even really consider the need for us to be able to prescribe the non-narcotic. Happy to announce that the second year that we went back and were granted a waiver, we had to present some outcome data, which is also on here. And the rule has been changed for the entire state. So the rule basically reads now that for the treatment of psychiatric disorders, non-narcotic controlled substances can be prescribed via telehealth. As part of the outcome study that the Board of Medicine required us to do, we did a control group with traditionally seeing clients and telehealth. And what we found, and none of this should be really shocking, is that clients are more likely to seek treatment due to the convenience factor. And I also always throw in here, there's still a large stigma attached to the treatment. And so folks not having to go to a doctor and perhaps being seen by somebody they know, be seen in their convenience of their own home is also a big part. Clients are more likely to stay in treatment, less likely to cancel or no-show. Before we started telehealth, our no-show rate was anywhere from 30 to 60% for our psychiatric clinic. Since we have, if I report on it today, we're at 12%. So the fact that the clients are actually coming in via the telehealth and adhering to treatment is a really good outcome, and it's important. As you know, clients coming on and off medication is not a good thing. We're seeing clients more timely. The typical wait list for traditional face-to-face service to see a psychiatrist is anywhere from 3 weeks to 6 months. And ours was right up there with that. Right now, we can see you typically within 2 to 4 days. If it's an emergency, we actually can see you right away. So that is also, the access to care is huge with telehealth. 98% of our clients were satisfied. And then the key I always like here to point out is 10% fewer prescriptions were actually written to our telehealth group. We think that's due to compliance. And we also think that at least in the children, the younger population, our kids have grown up with using the smart devices. And I think there's a little bit more comfort being in your own home or being somewhere where it's just you, that the doctors are actually getting better information. We also, in conjunction with that, did a study at the University of North Florida, found pretty much the same outcomes. One of the key issues, and this is true for a nationally too, that the quality in both the control group and the telehealth group was exactly the same, and there was no decrease in quality of the services that were given. The same with access to care and medication adherence. All of our prescriptions, we're completely paperless now, are completed electronically. We use Dr. First. You can prescribe even though a lot of pharmacists in Florida didn't realize it at the time, but you can prescribe controlled substances via electronic, and we have a lot of cooperating pharmacies that work with our clients. We also have one group, depending on where you live, that will deliver the prescriptions to the clients free of charge within 24 hours. And they also help us with authorizations for the indigent program. And the beauty of the system, as well as our doctors can see, and it's getting better all the time, not only what we've prescribed, but they can see if the client has gone to other practitioners. So if their primary care practitioner has prescribed something, they're able to see that. Or if they're pill shopping, they're able to see that. And we have actually been able to catch a lot of that and discharge clients for that piece as well. One of the questions that always comes up is biometrics. Via telehealth, how do you get it? So we always say there's a Publix near you, and the machines that many of us often use are called Higgies to get our blood pressure taken. You can set up a personal account there that it tracks over time, and we have a relationship with Higgy that once the client has approved to release to us, that their biometrics are uploaded into our electronic health record every evening, so that our practitioners can get that data. We also ask them to, if they can't do that, they can go to their primary care practitioner or a fire department somewhere nearby. But we do have that set up for clients that are in need of it. Very easy to refer to us. This is our website. Actual picture of it. It's www.empower, spelled with an I, fl.org, and there's two big buttons: refer myself or my child, or refer another person. You just click those, it goes right to our central referral department, and all of our consents, everything now are done electronically. This is a copy of part of what the app would look like. As I said, Mend is our partner. They've been incredible with us in designing the system as we go. And from our contact information, that is where we are. That's my personal email here. And then all of our referrals we can take online. And with that, I think we're good for questions.
So I'm back again. Thank you, Anna. That was very informative. Looks like a terrific program that has a great future. For people that are more interested in learning more about telepsychiatry, I would refer you to the psychiatry.org, is the American Psychiatric Association. They have a big section there on telepsychiatry. I would also refer you to Academy of Child and Adolescent Psychiatry. So their website is aacap.org. They also have a big section on telepsychiatry. Psychiatrists across the country are aware that we're spread thin. Well, I guess we're not so much spread thin as clustered in big cities. We have a lot of representation in Washington, D.C., where they need all the psychiatrists they can get, as well as other cities that have big training programs. But people in those training programs are certainly reaching out to rural areas and using telepsychiatry services to make that happen. And glad that we have that in Florida. Dan, if you want to come back, do you have any closing remarks or comments?
I thought there was a couple questions coming in. I saw someone make provide a question regarding the combination of clonidine and guanfacine, and why we talk about not combining them. Clonidine is an alpha-2 agonist that crosses readily in the blood-brain barrier, and hence that's why it produces a lot more sedation. Guanfacine does so, but to a much lesser extent. The effects are peripheral. And there's been reports of interactions of the two where the bradycardia is a real issue, obviously associated with dizziness and a bunch of other things, but as well as this kind of paradoxical agitation when it's combined, and even aggression. And so with those difficulties in dosing and the difficulties of not having real clear guidelines of how to dose it, we struggled whether we should suggest it as a relative contraindication or whether we should just say stay away from it. And we kind of came to the conclusion, weighing the risks and the benefits, to try to stay away from combining those two. Even though people, as you all know, combine it, say, gee, I want to use guanfacine in the daytime because it helps, but it's less sedative, and clonidine at night. The potential risks are there, and at the very least, urging a lot of caution in combining them, the two, making sure the child is not cardiovascularly compromised or displays any kind of paradoxical behavioral side effects.
Anna, there are two questions for you. One is, do you use some pre-visit screening instruments, evaluation before some pre-visit questionnaires that you use for your visits? And the other question, which also would be related to telepsychiatry, is what is your process for handling acute crisis in the telepsychiatry kind of practice?
Our pre-visits, everything is done. I'm not sure if you're talking like a evaluation or just a background of referral. So we get referrals from the school systems all over. So we do sometimes get some background information. Everything is either done online, as you said, or as I said, all of that questionnaire is done. The individuals can fill it out online and just send it right back to us. And then depending on their need, if it's requesting a therapist or a psychiatric evaluation, our central referral and screening office will contact the client and get that information and make sure the appointment is set up for the right place. As far as acute crisis, one of the other, I forgot to mention this, the American Telehealth Association is also a very good resource for just telehealth in general. And when we set up our systems, we follow very closely what they have outlined there for crisis situations. Before you even can enter into a session with us, we require a photo ID to make sure you are who you say you are. We require an address of where you are at the moment, so that we know if something does happen, that we contact the correct authorities. It's a whole process. Again, we mirrored it basically at the American Telehealth Association. Knock on wood, we have not. We've been doing this for 6 years now, and we actually haven't had to go through that process. And ironically, in our office, it happens a lot. So it almost seems to be, again, we're just learning as we go. Having the individual somewhere where they're comfortable seems to keep them calmer, and they don't escalate like they do sometimes in the office. So our practitioner would call 911, and we would have an address and make sure we know. We also want to know who's in the home and there with them, that they're by themselves, so that we can actually provide that information if there is an emergency that happens. But again, knock on wood, we have not had to have that happen. But we do verify everybody, and we know where everybody is.
Dr. Castellanos, there's a question here I think that you could handle. So in children that have multiple symptoms, for instance, they're having aggression, they're having hyperactivity, impulsivity, ADHD-like symptoms, which would you target first? And do you have a preference of what medication you would use?
Absolutely. So this is one of the classic dilemmas. Children are complicated, and kids with neurodevelopmental disorders present with multiple problems. And part of what I was trying to allude earlier is that at some point, one has to make a decision about a hierarchy of priorities, which cluster is the most severe, which is the most impairing. Now, sometimes parents will say all of them, but at some point we have to make some kind of distinction and begin with one. And so it really depends, right? So sometimes improving the hyperactivity and impulsivity will help the aggressive behaviors. And sometimes the aggressive behaviors really are the main focus or the initial focus of intervention. And then from there you go tiering in or phasing in your other interventions. But you usually work with the family and other caregivers, and with your clinical judgment, you determine which do you consider the most severe or the most impairing. And then from there, you follow your protocols.
So there were a couple of last questions that I'll try to answer. One was about the use of anti-epileptic drugs in children with these behavior problems. From my own experience, I can assure you that they have been used. But I think when we developed these guidelines, we realized that the use of those medications are going to be way outside of anything that has any evidence base. So it's not anything we can recommend or even speak to. But certainly there are children where you've tried other interventions and other considerations. But I think the anti-epileptic medications would not be drugs of first choice. There was a question about lab follow-ups with guanfacine and clonidine. There are no lab follow-ups. Those really wouldn't have any particular effect, more blood pressure, heart rate kind of effects that you would need to use. And one last question for Anna. How do you do the physical examination or monitoring these other things? You mentioned the instrument, the Higgy at Publix, but is there an expectation that these children have other primary care or being seen in a primary care setting?
Yeah, we only do the psychiatry. So from the physical, the pediatric and internal medicine, we would work in conjunction with their primary care practitioner, or we would refer that out. We can obviously PA on site, but our focus is just on the psychiatry component of it.
And that being done, I think we'll close the conference and wish all of you a happy and safe, dry, comfortable, not too hot weekend.